This conference will now be recorded.
Hello, good afternoon. Today's class is an obstructed labor. Can you hear me? Can you hear me?
Yes, ma'am.
Yes, ma'am.
Okay. What is obstructed labor? It is a condition where, in spite of good uterine contractions, the progressive descent of presenting part is arrested due to mechanical obstruction. It's a condition where, in spite of good uterine contractions, the progressive descent of presenting part is arrested due to mechanical obstruction. Incidence is 1 to 2% in developing countries. What are the causes for this obstructed labor? It can be fault in the passage, fault in the passenger, that is the fetus, and fault in the power, that is the mother efforts. So what are the causes for the fault in the passage? It can be due to bony obstruction or soft tissue obstruction. Bony obstruction can be cephalopelvic disproportion or contracted pelvis are the most common causes. Come to the soft tissue obstruction, it can be cervical dystocia due to prolapse or previous operative scarring. So cervix won't be dilated. Or cervical or broad ligament fibroid, anything which is obstructing the path or impacted ovarian tumor. These are the soft tissue obstructions obstructing the passage. Fault in the passenger. So it can be due to malpresentations where it is difficult to go through the passage. So transverse line, bro presentation, occipito-posterior, when there is compound presentation, and congenital malformation of the fetus such as hydrocephalus, fetal ascites, and double monsters, big baby, and Lockett twins. So once again, I am repeating transverse line. Most of them are malpositions and malpresentations. These are transverse line, bro presentation, occipito-posterior, compound presentation, and congenital malformation of the fetus such as hydrocephalus, big head, fetal ascites, and double monsters, big baby, and Lockett twins. So what will happen when you have obstructed labor? The clinical features will be patient will be in agony from constant pain and become restless. Features of exhaustion and ketoacidosis will be present. Okay. Upper segment is harder and tender and lower segment is distended and tender. So what will happen then when the patient is having obstructed labor? See here, there will be a circular groove. This is normal labor. Okay, in obstructed labor, a circular groove encircling the uterus, this is the one, okay, is formed between active upper segment and distended lower segment. This is called pathological retraction ring or Van Leest ring. This is important. This will happen. What are the changes which occur when the patient is having obstructed labor is the development of Van Leest ring. Where it will occur? Between the active upper segment and distended lower segment. Not only that, the bladder will become an abdominal organ. The bladder walls are ready to traumatize, leading to blood-stained urine. What will happen? The presenting part of the fetus will compress the bladder base. The bladder will get compressed between presenting part and symphysis pubis. Whenever there is compression of the or obstruction to the bladder, what will happen? Tissue, there will be pressure necrosis. This pressure necrosis will slough off in later point and they will develop genitourinary fistula. Okay. Again, I am repeating. The bladder will get compressed between presenting part and symphysis pubis. Presenting part and symphysis pubis, bladder will present before the fetus and behind the symphysis pubis, you know that. So because of obstruction, the bladder will be compressed. Where base of the bladder? Which part of the bladder? Base of the bladder. So what will happen? There will be pressure necrosis. So there won't be any blood supply. That leads to sloughing of the necrosed tissue and get infected and slough off. That develops into the genitourinary fistula. This is the one of the complication we will it will come across in our field. So what are the effects on the mother? The mother will be exhausted because of pain and agony. She can have dehydration because of decreased intake of oral fluids or IV fluids is not taken. Genital sepsis she can develop. Why they can have genital sepsis? Because of prolonged labor, rupture of membranes, and because of repeated pervaginal examination. Injury to the genital tract and ruptured uterus is usually seen in multiparous. Okay? Or if you apply, try to apply any forceps. And not only injury to the genital tract, also includes injury to the bladder. And PPH and shock and metabolic acidosis, these are the immediate complications of the mother. So the mother may be exhausted, dehydrated, and she may develop genital sepsis. Injury to the genital tract and ruptured uterus are accounted, PPH and shock and metabolic acidosis. Remote complications, I already told you, they may develop vasovaginal fistula, rectovaginal fistula, vaginal atresia, and secondary amenorrhea. And what are the effect on the fetus? The fetus will get asphyxiated. And fetal hypoxia leads to acidosis, intracranial hemorrhage, infections. All this can lead to perinatal loss. So the fetus can be asphyxiated because of hypoxia and asphyxia. They may go into acidosis. And this is also encountered because of maternal acidosis, intracranial hemorrhage, infection, and more perinatal loss. Clinical features already I told you, and how we are going to prevent this. Mainly during the antenatal period. I already told you what are the causes for the obstructed labor. Fault in the passenger and passenger. These are the cases when you come across, such as transverse line or CPD is you should assess before delivery. Contracted pelvis, everything you should assess. Or if the big baby, malpresentations, positions, any fibroids, everything should be screened in the or detected in the antenatal period. In the internatal period, during the time of labor, what you want to do? We have to watch the patient with continuous vigilance and we should use partograph. And timely intervention of prolonged labor due to mechanical factors can prevent obstructed labor. Then we should know about the partograph. What is the partograph? It is a composite graphical recordance or key data, maternal and fetal during labor. This is graphical, they will record the maternal and fetal aspects during labor, entered against time on a single sheet of paper. Okay, see, I will show you the partograph. This is the partograph. What are the things which are there? First, there will be patient name, when she was admitted, time of admission, when the membranes are ruptured, and fetal heart rate. Here they are given fetal heart rate. Then, when the membranes are ruptured, what is the color of the lichen? Then, this is alert line and action line. This is drawn again as cervical dilatation and hours. Okay, it is alert line should start at the, can you listen me? At 4 centimeters and action line 4 hours apart from alert line. These two lines are given before only. And we have to start where the patient is in which dilatation. If she is on 4 centimeters dilatation, we have to plot on this like this. Into marks we have to keep. So if the patient is not progressing in the same pattern of alert line, then if she comes between alert and action line, we should take some action. What is the action we have to take? Either we have to give oxytocin, or we have to assess the patient whether she can deliver or not, or we have to increase the syntocin or rupture of membranes. We have to do. If the graph is coming under action line, immediately we have to do some action. That is, we have to terminate the pregnancy by cesarean section. And what are the things here? Next is contractions. Okay, contractions, good contractions. What do we have to plot? How long in 10 minutes? How many times she is getting the contractions, and how it intensity of the contraction, and how long it lasts. Then comes the oxytocin or any drugs you are giving. This is the one more thing. Any IV fluids we are giving, we have to write here. Then patient pulse, BP, urine output, temperature, and urine examination also we have to do. It includes protein, acetone, and volume. These are the things which is so altogether in the partograph. This is a short answer for you in the final exam also. The patient address, then fetal heart rate, membranes, alert and action line, uterine contractions, then oxytocin drip, drugs given, IV fluids, pulse, BP, temperature, and urine examination and urine volume. This all includes in the partograph. See, in a partograph is first started by WHO in 1994. It consists of latent phase and active phase. Latent phase, the latent phase is what? It ends at 4 centimeters, 0 to 4 centimeters. Active phase is starts with cervical dilatation of 4 centimeters. So alert line, already I told you, this is the alert line. This is the alert line. See? This is the alert line. Alert line starts at the end of latent phase, that is 4 centimeters, and end with full dilatation. See, this is 4 centimeters dilatation, and with full dilatation, that is 10 centimeters. This is the 10 centimeters. So we'll start with 4 and end with 10. The action line is drawn 4 hours to the right of alert line. The interval of 4 hours is allowed to diagnose delay in active phase, and an appropriate intervention is done. So action line is started 4 hours from the alert line. See, this is the time schedule. So 4 hours from the alert line. This is the hours 1, 2, 3, 4 hours. This is the dilatation. So 4 hours from the alert line will start action line. Okay. The underlying principles, actual treatment, what we have to see, when we have to interfere by using partograph. Actual treatment is, the underlying principles are to relieve the obstruction at the earliest by a safe vaginal delivery, or to combat dehydration and ketoacidosis, and to control sepsis. Our main aim to remove the obstruction. She can have vaginal delivery or cesarean section, anything can happen, or when we have to treat the dehydration and ketoacidosis, and we have to control the sepsis. Correction of dehydration and ketoacidosis by rapid infusion of ringer lactate, at least 1 liter, is to be given in a running drip. A vaginal swab for culture and sensitivity, because we have done so many pervaginal examinations, PROMS already done, and blood sample is sent for grouping and cross matching. If necessary, blood can be given, and higher antibiotics such as monocept, that is ceftriaxone 1 gram IV is administered. And if necessary, for a control of anaerobic infection, metronidazole also can be given. And obstetric management. Before proceeding for definitive operative treatment, rupture of the uterus must be excluded, especially in the multi-para. There is no place for wait and watch policy or any use for oxytocin to stimulate the uterus once again. Usually in obstructed labors, the baby will be usually dead. If the baby is low lying, if the baby is dead, forceps extraction can be done if possible. Otherwise, you can go for the cesarean section. Okay. If the case is detected early with good fetal condition, cesarean section gives the best result. Okay, we can go for, if the baby fetal heart rate is good, we can go for cesarean section. If the baby is dead, or we can go for vaginal delivery is possible, means we can go for forceps extraction. And after the delivery of the baby, always after expulsion of the placenta, exploration of the uterus and lower genital tract should be done to exclude any rupture or any tears. Okay, this is obstructed labor. I think you understand. Again, I am going back. Obstructed labor definition is, they will ask you an exam. Obstructed labor is, it is a condition where in spite of good uterine contractions, the progressive descent of presenting part is arrested due to mechanical obstruction. Fault in the passage, passenger power. So these are the fault in the passages. Passenger is the malpresentation and malpositions, big baby, locked twins, anomalies. And what Bandley's ring is the pathognomic feature in obstructed labor. And the chances of bladder-based injury is more common because of compression between the presenting part and the symphysis pubis. Effect on the mother, exhausted mother, dehydrated, ketoacidosis, injury to the genital tract and ruptured uterus, PPH and shock are the immediate complications. Remote or fistulas, vesicovaginal fistula, rectovaginal fistula, atresia and secondary amenorrhea. And for baby, asphyxia, acidosis, hemorrhage and infection. Okay. Antenatally, we have to detect the factors responsible for the prolonged labor and we can opt them for cesarean section. Number 2, in the internatal period, partogram is important. Partograph features and what are the components are very much important. They will ask you in the exam and we have to plot in the exam also. Then we have to treat the dehydration, ketoacidosis, control sepsis, obstruction to be relieved, higher antibiotic and blood to be arranged and vaginal swab to be taken. Obstetrical management or wait and watch policy is not advised. Immediately we have to take the action and we have to see whether there is any rupture. And the baby is good, we can go for the cesarean section. Otherwise, if possible, forceps extraction and vaginal delivery can be allowed. There is no place for internal version. After the completion of the delivery and expulsion of the placenta, exploration of the uterus and lower genital tract should be done to exclude uterine rupture. Okay, thank you.